what is required in antecedents is that we have the glands that are working and secreting the hormone, and we have the tissue cells. Ladies, I know you're probably working on another class project, but
No, they're trying to help me get logged. She's trying to help me get logged in.
okay,
It's
all right.
not working. Does anybody else have an issue?
It's the internet.
The internet is keeping people.
Okay, well, then, thank you.
I think every 2 hours is log.
I'm like, so that's what we're doing.
It tells you you need to take a break, is that what it is?
No, they kick you out.
Picture of that. I'm like,
I know it was doing that on testing the other day,
I'm like,
kept
what are the
kicking
classes
people
we
in.
working on? We not working on no class. We just trying to
Okay,
get into the-
all right, thank you. So, going back to metabolism, yet another gland that, we need to be aware of, one that has a huge impact on our patients is the thyroid. So we can have hyper or hypo. The scope is, again, like Goldilocks, perfect, too much or too little. Hypo, not the page together. So, the name of the marker is listed there on the PowerPoint. You do need to be aware of what normal ranges are for each of the TSH, T4, T3, okay? Have a working knowledge of what the normals are. You start with hypothyroidism. Deficiency in thyroid hormone, more common in women than in men. The TSH will be over 4.5. T4 level is normal. Affects up to 10% of women over 60. It mimics the aging process, so it often goes undiagnosed in older adults because we make so many assumptions about older adults that we miss a lot of the cues on things that could be fixed, and this is one of them. And that hypothyroidism, everything slows down, doesn't it? Metabolism slows down, you gain a little weight, and we just assume that when we see those things in an older adult, well, that's part of the aging, but not necessarily. It could, hypothyroidism mimics aging process. It's a deficiency in the thyroid hormone, and it causes just a general slowing of everything, a decrease in metabolism. About 4% of the United States population has mild hypothyroidism, and 0.3% have a more severe disease. Common in women, they are affected 7 to 10 times more often than men. Critically ill patients may represent a non-thyroidal illness syndrome called NTIS. They will have a low thyroid, low T3, T4, and THS levels. It also can be caused by this insufficiency can be because of the thyroid hormone not being produced by the thyroid or by dietary intake such as iodine or thyroxine. Thyroid hormones influence metabolism. The signs of hypo are fatigue, weight gain, depression, decreased cardiac output, decreased heart rate, decreased respiratory rate, most often among women 30 to 60. Decreased production of the thyroid hormone results in decreased blood levels of the thyroid hormone, which decreases metabolic rate. A lower metabolic rate increases TSH because the TSH is trying to stimulate the release of T3 and T4. And if it's low, the body's gonna try to stimulate that level to go up by sending out the TSH hormone. And as the TSH hormone goes up, it causes the thyroid gland to enlarge and we get a goiter. So even though the thyroid stimulating hormone is being released to try to stimulate the T3 and T4 levels to go up, it's not working. So it keeps going up and they don't change. Primary hypothyroidism is due to destruction of the thyroid tissue or some defect in the hormone synthesis. Secondary hypothyroidism is due to the pituitary or hypothalamic dysfunction. They're not, in this case, secreting thyroid stimulating hormone or the thyroxine release hormone. Either way, it ends up whether there's no secretion of T3 and T4 by the thyroid or no secretion of TSH and TRH by the pituitary or hypothalamus, the end result is still the same, is hypothyroidism. Etiology: primary is decreased thyroid tissue due to surgical or radiation-induced destruction, autoimmune, a congenital poor development, cancer. Drugs, lithium. Secondary is due to inadequate production of TSH by the pituitary, could be due to trauma, tumors, infection, a congenital defect, hypothalamic tumors, trauma, infections, or infarct. So any of those reasons, whether it be the pituitary or the hypothalamic issue that causes decreased production of TSH and TRH, that causes the secondary. Okay, just email Dr. Ross too, okay? Okay, so risk factors, double whammy, being female, being over 50. Close relative to autoimmune conditions, had thyroid surgery that radiated to the neck, or radioactive iodine, or any anti-thyroid medication can send you into hypothyroidism. Iodine deficiency, Hashimoto's thyroiditis. It's the most common cause of goiter and of primary hypothyroidism. Again, more common in women. Family genetics. Also medications, lithium and amiodarone. Clinical manifestations, heart. We significant in patients with pre-existing cardiovascular diseases. You have decreased cardiac contractibility, decreased output, you have increased cholesterol, increased triglycerides, anemia. Respiratory wise, you're gonna see a low exercise tolerance. Remember, it's hypo. Everything's kind of slowing down and pulling down, right? Shortness of breath on exertion, fatigue, lethargy, personality and mood changes, impaired memory, slowed speech, decreased initiative. Does that sound like something that you would expect in somebody who's over 50? So you can see why it's not diagnosed sometimes, because it's just things that, oh, I'm just getting older. I'm just, and that's not the case. We always need to look deeper. Be a patient's advocate. Also, we're going to see bradycardia, hypotension, cold intolerance, constipation, everything that goes with slowing down. Many individuals with hypothyroidism appear depressed, but it's not related to depression. They may be fatigued, they may be irritable. Gastrointestinal system, they will have a decreased appetite, may have nausea and vomiting, weight gain, constipation, distended abdomen, and a large scaly tongue, celiac disease. Their skin is going to get, they're going to have thick, brittle nails, they're going to have cold skin, their hair is going to be coarse and sparse, poor skin turgor, poor mucosa turgor, puffy face, decreased sweating, pallor. They're going to have decreased taste and smell. You're going to see hair loss and thinning hair. Because they do mimic age, people are going to let some of this stuff slide. And if you have a patient who suddenly is showing signs of dementia, might be one of the first places to look to see if that might be the clinical reason for it. As far as your muscles, you're going to see more fatigue, more weakness, muscle aches and pains, slow movements, reproductive system, prolonged menstrual periods, or even amenorrhea, decreased libido, infertility problems, increased susceptibility to infection. They're going to be very sensitive to opioids and barbiturates and anesthesia, so they're going to see more side effects because remember, they're slowed. Everything's slowing down. And what did we talk about already with opioids? Why do they already have problems with side effects with opioids in the first place? Have a slowed clearing of it due to their kidneys and liver, and if you put hypothyroidism on top of that, what do you think you're going to see? Opioids, and if someone's taking an opioid and they have hypothyroidism, especially if it's not treated well, they're going to have a really high increase for sedation, respiratory depression, because they are slowing, and they already have that slowed reaction to clear out their medications. You may see cold intolerance, decreased hearing, sleepiness, a coarse raspy voice, and goiter. People with severe long-standing hypothyroidism may develop myxedema, which is a physical appearance of the skin and subcutaneous tissues. It's life-threatening complication of untreated hypothyroidism, severe metabolic disorder, hypothermia, edema around the eyes, feet, hands, cardiovascular collapse, impaired mentation, coma. They have a puffy face, periorbital edema. They have a mask-like effect. We're going to see an altered self-image related to their disabilities and their altered appearance. It's precipitated by trauma or central nervous system depressants, failure to take their thyroid medicine, use of central CNS depressants, infection, exposure to cold. Treatment is to maintain the patient's airway, fluid and electrolyte, acid-base balances, maintain their cardiovascular status, increase their body temperature. They're going to have a lowered body temperature. Check their thyroid hormone levels, administer their thyroid replacement medication, in fact, treat with IV thyroid hormone. Emergency care is to have a patent airway, replace fluids, give levothyroxine sodium per IV, give glucose per IV if needed, check their body temperature hourly, monitor their blood pressure hourly, keep them under warm blankets, check their mental status, turn every 2 hours, and institute aspiration precautions. Diagnostic studies, in addition to history and physical, will be checking their thyroid, checking their TSH, their T4. This gives you a picture of if it's primary or secondary, what you're gonna see in the test results. As I was talking about earlier in the primary, the TSH level is gonna be higher because your pituitary is it's doing its job. It's telling the thyroid to secrete the T4, T3. And it's sending out its messenger, TSH, to tell them to do that. But something's messed up there and it's not secreting. So TSH keeps being put out there by the pituitary saying, okay guys, maybe you didn't get my first message, let me send some more. And so that TSH is going to be up while the T4, T3 will be down because they're not doing their job. The secondary is when pituitary or the words just left me. Hypothalamus, they're not doing their job of secreting the TSH, so that will be low. And because there is no TSH being sent messenger to the thyroid to increase T4 and T3, they're going to be low as well. So you understand why there's a difference? And why, even though it's hypothyroidism, the TSH is different based on where the problem is. You're also going to check their cholesterol. The most reliable laboratory test for thyroid function is the TSH and the free T4. They are most correlated with, that confirm a hypothyroid diagnosis. And you look at the TSH to see where the problem is. Is it primary or secondary? Is it in the thyroid? Is it a thyroid problem, or is it a pituitary or hypothalamus problem? Collaboration, you're going to give the levothyroxine treatment of choice. Replace the thyroid hormone, monitor for chest pain, dysrhythmia, weight loss, nervousness, tremors, insomnia. Why do you think chest pain and dysrhythmia is a problem? What's been going on in these patients' body? They didn't get what? They're hypo, so their body's doing what? Slowed down, correct? Kind of went into hover sleep mode. You know, like your computer going into sleep mode because it didn't get these hormones that keep us revved up, keep us going. And it kind of got adapted to that. Well, now you're going to fix it by doing what? You're going to give them hormone replacement therapy, which is going to rev things up, right? Well, you might rev things up a little too much, correct? And if they already have cardiovascular disease, and you rev them up and you increase their heart rate and you're increasing their pulse and you're increasing their cardiac output, when that heart wasn't ready for that change, you might see some adverse effects because it kind of got lulled down into this, oh, I'm going to go to sleep pattern. And then we decide to fix it by stimulating their T4, T3, getting their thyroid up, and that kicks their body into, uh-oh, I wasn't prepared for this. And if they already were compromised with cardiovascular disease, then you might see some issues going on with their heart rate and their arrhythmia problems, okay? So they need to report chest pain, nervous sensor tremors. All of this stuff's getting hyped up, and they're not used to this, so it could be that you are giving them a little too much. In hypothyroidism, we're going to see weight gain, and when we administer these replacement thyroid hormones, we may see weight loss, but it doesn't need to be a dramatic thing, okay? It might take up to 8 weeks for the full effect of hormone therapy to be seen. Levothyroxine peaks in about 1 to 3 weeks. Always educate our patients to continue to take that medication on a regular basis, okay? They don't just stop it, because how long are they gonna have to take hormone replacement therapy? For their lifetime. And if it's not like something that they get back up and they feel better, oh, I feel better now, I can not take it, right? They're gonna go back to where they started. The same way with children as in older adults, start low, go slow with the dosage. So you don't just throw out a dosage there. You start them on a low, slow dose and you build it up over time. They may have surgery to remove the border as well. There are newborns that are born with hypothyroidism. There is screening programs that test their blood for T4, TSH. As a result of the screening, we have less number of children that have intellectual disability as a result of hypothyroidism. The goal for new children is for them to have normal growth and development by restoring their T4. Again, they're going to be on oral hormone replacement, treatment of choice. They'll be evaluated every few months the first 3 years of life. And they're going to be on thyroid replacement therapy their entire life. Pregnant women, Hashimoto disease may be a cause, inadequate treatment for their hypothyroidism. Whenever you're pregnant, things need adjusting, and if the replacement hormone has not been adjusted, the dosage, then you could have an issue that you're back down to being hypo again, because your body's working really hard when it's pregnant, right? So it needs extra boost. Also, a reason for hypo is destruction or removal of the thyroid gland before pregnancy. There are issues with preeclampsia, anemia, miscarriage, low birth weight, stillborn, CHF is rare. But there are negative effects on the fetal growth and brain development if not treated and uncontrolled. So you don't want to ignore hypothyroidism in pregnancy. The effects on the fetus and on the parent and on the mom. Clinical manifestations: extreme fatigue, cold intolerance, muscle cramps, constipation, problems with concentration and memory. Treatment: thyroxine. May have to increase the dose if it was pre-existing. The goal is a healthy mom and a safe fetus delivery. Older adults, high risk for hypothyroidism. Why is that? What happens to your glands as you get older? What happens to your body systems as you get older? They don't work as well as they did, so thyroid's right there along with that. Atrophy of your glands, symptoms of aging may be misdiagnosed as hypo there. Diagnosis must be based on lab data, not on symptoms. For older adults, go slow. Start low and go slow, because we don't want to throw a lot of thyroid hormones at them. Be conservative, because that increases their myocardial oxygen demand, and that increases their risk for angina, MI, and arrhythmias. They've been in slow mode, And then if you give them the thyroid too fast, too much, it may kick them into cardiovascular issues. Treatment starts out at 50 milligrams a day. Decrease it by 25 milligrams for people who have coronary artery disease. Nursing assessment. Observation, looking for symptoms, we've already talked about. Rule out hyperthyroidism with medications, radioactive iodine surgery, routine head and neck cancer with radiation. Diet, iodized salt, respiratory difficulties. Physical exam, you're going to be looking for muscle strength, deep tendon reflexes, vital signs, cold intolerance, constipation, signs of depression. Check their heart rate, check their gland tenderness, check for edema. Nursing diagnosis, cardiac output is decreased. Everything here in hypo is slowed down, right? So we have a decreased cardiac output, we have constipation, maybe impaired skin integrity, situational low self-esteem, maybe signs of depression. They're going low and slow and they don't really know why, right? So they may even be depressed too. Planning, they won't have any arrhythmias. We don't want to fix them too much and mess it up, right? Skin's going to be warm and dry, they're not going to be cold. They're going to be free of edema. They're going to maintain visual acuity. They're going to participate in activities without having an excessive heart rate or shortness of breath. Their elimination pattern is going to return to normal. They're not going to have any skin integrity issues. Monitor their blood pressure, their rate, rhythm. Monitor the respiratory rate. Suggest that they do, that they wear socks or a sweater so that they don't become chilled. Explain their need for periods of rest with activity. Report any breathing difficulties, report any chest pain, report any heart palpitations or dizziness. Monitor their skin for redness and lesions. Provide measures that promote circulation, teach them to teach them a turning schedule if they're on bed rest. Limit time sitting in one position. Use pillows, pads, whatever you need to protect their skin. They need a schedule of range of motion exercises. Provide and teach patient measures for skin integrity. They don't need a daily bath, a whole bath. They need baths as needed because their skin is at this point in time is very susceptible to dryness. Alcohol-free skin oils and lotion. Skin integrity, they're very susceptible to skin breakdown. Prevent constipation, encourage fluid. Discuss preferred liquids and the best time to drink them. If they're an older person, do they want to be drinking a lot sometimes at 6 o'clock at night? What's that going to interfere with? You're going to have to get up and go to the bathroom. It's going to interrupt their sleep. Gradual increase in activity. Increase fiber in their diet. Use stool softeners and a regular bowel elimination time. Expected outcomes, that their vital signs are going to be within normal limits, and especially with activity. They're not going to have, they're going to have a normal cardiac rhythm. Their skin's going to be intact. They're not going to have edema. The visual acuity is within established limits. Their elimination pattern is going to be within normal limits. If outcomes not met, we're going to modify and make changes and repeat diagnostic tests to ensure that medications are at an appropriate level. It's not a one and done thing, if there's not a magic number of what the milligrams they should be receiving. So it's one of those things that you wait and see. So you give it, and make a dosage change based on what the lab results are and based on what symptoms they are experiencing. Hyperthyroidism, what do you think that means? Up or low? Hallmark sign is what? And looking at someone's face. The eyes, right? So, hyperthyroidism is excessive thyroid hormone, results in exaggerated normal body function. So it's a state of hypermetabolic state. Things completely opposite from hypo, where you go into sleep, kind of like computer sleep mode. Kind of, okay, I'm just shutting down here for a little while. Now in hyperthyroidism, we are revved up, okay? So you have thyroid hormone levels affect protein, fat, and glucose metabolism, protein breakdown, have a net loss of body protein, decreased glucose tolerance, results in hyperglycemia, increased fat metabolism, results in weight loss. Lots of people are really mad when you fix their hyperthyroidism. It says they lost a lot of weight. And some people will get upset that, oh, they fixed it and I gained weight. It's not a very easy way to use this to lose weight, but some people do have weight loss and are not happy when you fix it. Increased fat metabolism results in weight loss and nutritional deficit. You have increased thyroid hormones, and you have decreased thyroid stimulating hormone. Females have menstrual problems and decreased fertility. Both men and women have increased libido. More common form is Graves' disease, 75%, 5 times more often in women. Other causes are goiter, thyroiditis, excessive iodine intake, pituitary tumors, and thyroid cancers. The autoimmune antibodies result in a hypersecretion of thyroid hormones. So you have a serum TSH level below 0.04. You'll have normal T4 and T3 levels. Overt hyperthyroidism, low or undetectable TSH, elevated T4 and T3. Symptoms may or may not be present, but increased level of T3 is the best indicator of hyperthyroidism. It's a better indicator than the T4. Graves' disease, autoimmune disease characterized by thyroid enlargement, excess of thyroid hormone secretion. Factors are insufficient iodine supply, cigarette smoking, stressful life. Precipitating factors and genetic factors interact to create hyperthyroidism. Development of antibodies to TSH receptors stimulates secretion of T3 and T4, and it further leads to thyrotoxosis. Clinical manifestations, we know about the eyes, right? That's kind of one of the first. Club fingers, normal, you have a distorted angle to the nail beds. The protrusion of the eyes results from increased fat and fluid deposits in the orbital tissues. Intolerance to heat with hyper, fine straight hair, bulging eyes, facial flushing, enlarged thyroid, heart rate is up here, increased systolic blood pressure, breast enlargement, weight loss, muscle wasting, localized edema, increased diarrhea, tremors, nervous, irritable, hyperactivity, decreased attention span, weak, easily fatigued, exercise intolerant, heat intolerant, weight loss, increased appetite, can't sleep, you're gonna complain of insomnia, frequent stools, diarrhea, warm, sweaty, flushed skin, fine textured hair, sensitivity to light, vision changes, brewery over the thyroid, increased blood pressure, increased systolic pressure, increased heart rate, dyspnea. General observation, agitation, rapid speech, rapid body movement. They have trouble sitting still. Warm, diaphoretic, velvety skin. Sounds like a commercial. You know, some of these products I've seen on TV, well, we would give you velvety skin, fine silky hair, weight loss. You might want to sign up and get a bottle of it, right? Breast enhancement, what else? I mean, when I think about all the things that you see on TV commercials that are, oh, take this product. Tachypnea, dyspnea on exertion, increased bowel sounds, increased appetite. Increased appetite but have weight loss. That should always be a signal to everybody that there's a problem somewhere, correct? The same with diabetes. A diabetic will have stomach issues, they will have increased hunger, but they have weight loss. And the two of those don't normally go together in the real world, do they? So that should be a sign to to anybody that something's afoot here. Fine tremors of the hand, tongue, eyes, muscle wasting, reproductive issues. Hashimoto's thyroiditis is destruction of the thyroid tissues. Most common cause are hypothyroid goiters, high risk in females, especially with the family history, older age, white ethnicity. The goiter is the hallmark of Hashimoto's. They have a transient phase of hyperthyroidism. Thyroid hormone will be low, TSH level will be high, and anti-thyroid antibodies will be present. Antibodies for surgical drainage, NSAIDs, thyroid hormone therapy, hypothyroid. Older and younger adults, common cause, Graves' disease, common symptoms, nervous, irritable, adults weight loss, depression, confusion. Younger adults have the goiter more often than the older adult. Younger adults have the ophthalmopathy more than the older adults. Cardiac, more tachycardia, but without heart failure. Older adults have dysrhythmia, especially atrial fib, and they may have heart failure. Remember, the system does not work quite as well. The organ is not working like it did, and then you put this increased pressure on it, it's going to have issues too. Acute thyroid I cannot say this, thyrotoxicosis. Excessive amounts of hormone release is life-threatening. It's called the thyroid storm, okay? Death is rare when treatment is initiated, but it is life-threatening. Results from stressors. Thyroidectomy patients are at risk. They have severe symptoms, severe tachycardia. heart failure, shock, hyperthermia. Temperature can be up to 106 degrees Fahrenheit. They're agitated, they're delirious, they're have seizures, abdominal pain, vomiting, diarrhea, coma, thyroid storm. It's acute, it's rare. The patients undergoing thyroidectomy are at most risk because of the manipulation of the thyroid gland results in an increase in hormones being released. So that's one of the triggers. Although it can also happen from stressors such as infection, trauma, surgery, anytime in a patient that's got pre-existing hyperthyroidism, these stressors can trigger it. Emergency care. Airway, adequate ventilation, give oral anti-thyroid drugs. Huh?
It just mean the phone keep ringing and nobody look, like nobody there. Nobody knew.
The mystery found, I guess. Administer sodium iodine solution, 2 grams IV, give propranolol 1 to 3 milligrams, give slowly, give glucocorticoids, monitor the cardiac dysrhythmias, vital signs every 30 minutes, provide comfort measures. We're not gonna put a warming blanket on them at 106 temperature. What are we gonna put on them? A cooling blanket. We're going to administer antipyretics. We're going to correct their dehydration. Might have to apply ice packs to reduce their fever if it's really gotten up. Diagnostic studies. You're going to find TSH will be down, T4 up. Laboratory tests, we're going to have increased basal metabolic rate. It's really it's a revved up form of hyperglycemia. Hyperthyroidism. Doesn't think we talk about diabetes today. Goal is to block the adverse effects of the thyroid hormone, suppress hormone secretion, prevent complications. Prescriptions are going to be anti-thyroid medications, radioactive iodine therapy, surgical intervention, support therapy, managing respiratory distress, reducing their fever, replacing fluids. What happens when your temperature's that high? You're gonna be burning through a lot of fluid, won't you? And your heart rate and everything's gonna be up because you're on hypermetabolic state. You're revved to the top. So all systems are gonna be burning your fuel quickly. So gonna have to support with fluid replacement, getting their temperature down, getting their heart rate and their respirations down, monitoring for cardiovascular issues, and eliminating and managing their stressors, especially if they have an infection or if they have something else going on. The anti-thyroid drugs, the iodine, all these are not, they are useful in the treatment, but they're not going to be curative. Expect to see improvement in 1 to 2 weeks, good results in 4 to 8 weeks, and have therapy for 6 to 16 months. It's a matter of trying to pull all that thyroid hormone that got dumped out with the manipulation and the thyroidectomy, all that, getting that all to calm back down and become more manageable instead of having a storm. During all this time, when you're trying to get it down, what do we tend to do? Whenever we have something on the extreme and we're trying to pull it back in, what do we have a danger of? Over correcting, correct? So, we're gonna try to inhibit the production of the thyroid hormone, but we also don't wanna send them into severe hypothyroidism either, correct? So, anytime in all of this, they swing the other way, when they had a temperature high and now they're freezing cold again, they got bradycardia, all that, so it's a continuum, and it's so easy for us in our overzealous attempt to cure this problem, we throw them into the opposite. So always be assessing them to make sure that we're not sending them over the edge there. Drug dosage for the propyl ioduracil. Teach the patients to avoid crowds, people who are ill. The drug reduces red blood cell counts and the immune response, so there are increased for infection. Teach them to report darkened urine, yellow appearance, might be a sign of liver toxicity or liver failure. Check their weight gain, check slow heart rate, cold intolerance, may indicate that we overcorrected too much and that the dose needs to be adjusted. Report fever, sore throat, jaundice, bruising. Take the medication with meals. At the MISO, remind women to notify if they become pregnant because the medication does cause birth defects and it should be stopped if a woman is pregnant. Same thing, there are increased for infection, and also, as always, a risk that we have overcorrected in the dosage, and that the dosage needs to be adjusted. So watch for signs of hypothyroidism. Glucose solution, saturated solution of potassium iodine. Administer them 1 hour after a thiamide has been given. Initially, the iodine agents cause an increase in production of the hormone, thyroid hormones, but giving them the thionamide first prevents this initial increase. Check patients for fever and rash. Ask about a metallic taste in their mouth, sores, GI distress. These are signs and symptoms of iodism, which is a toxic effect of the drugs and may require that the drug be discontinued. So, iodine beta blockers. Potassium iodine, glucose solution inhibits the synthesis of thyroid, blocks the release of thyroid hormone, decreases the vascularity of the thyroid gland, has its maximum effect for 1 to 2 weeks. It's used before surgery and to treat the crisis. Beta blockers give symptomatic relief. They block the sympathetic nervous system. Use propranolol and altenolol. Radioactive iodine therapy is a treatment of choice in non-pregnant adults. It damages or destroys the thyroid tissue, although you may not see the full response up to 3 months. You treat with anti-thyroid drugs and beta blockers before and during the first 3 months of the radioactive iodine therapy. Have the patient teach them the signs and symptoms of hypothyroidism. Pregnancy test is required. Monitor for dryness of mouth, irritation. Limit exposure. Surgical therapy. Large border causing tracheal compression. Unresponsive to anti-thyroid therapy. gonna have surgical therapy. Thyroid cancer, or if they're not a candidate for the radioactive iodine, they won't have surgery to remove their thyroid. Causes a rapid reduction in the thyroid hormone. It is a preferred surgical procedure and involves removal of about 90% of the thyroid. It can be done using minimally invasive procedures, including robotics therapy or surgery. Nutritional therapy, high calorie diet. They're in full metabolic hyper state, so they're gonna be eating through a lot of calories initially. 6 full meals a day with snacks. Protein intake should be 1 to 2 grams per kilogram of ideal body weight. Increase carbohydrate intake. Avoid highly seasoned food, fibers, caffeine, and they will need a dietitian referral to help meet these nutritional needs, because we don't want them just taking in calories, right? I mean, we don't want them just to take in calories, we want them to be a balanced diet to help with the healing. Lifespan considerations, children, affects growth and development. Have issues with distractibility, unexplained poor school performance, emotional liability. Emotional liability. Puberty not accelerated or not altered in the hyperthyroidism. Girls who've undergone may develop amenorrhea or secondary amenorrhea for their ovulatory cycles. Pregnant women, usually caused by Graves' disease. If it's pre-existing Graves, they may see remission during the 2nd or 3rd trimester. General suppression of immune system during pregnancy. The disease process gets exacerbated during the first few months. They may have hyperemesis gravidarum, high levels of HCG cause temporary hyperthyroidism, usually resolves during the 2nd half of pregnancy. Can result, if it's uncontrolled, in coronary heart failure, preeclampsia, thyroid storm, miscarriage, premature birth, and low birth weight. Newborn hyperthyroidism in newborn can result in rapid heart rate, can lead to early closure of the fontanelles, poor weight gain, irritability, breathing issues. Older adults, toxic nodular border, more often in Graves' disease. They may only have 1 or 2 symptoms. Remember, older adults don't always react the way other people do. Treatment is anti-thyroid drugs, radioactive iodine. Surgery is rarely recommended in older adults due to operative risk. Must be carefully monitored for treatment, especially in the initial phase. Nursing assessment, gonna look for subjective data, past history, pre-existing goiter, information about infections or trauma, or if they've immigrated from a iodine deficient area. Also ask questions about autoimmune disease, if they've taken or used thyroid hormones in the past, if they're presently taking them, herbal therapies that may contain thyroid hormone. Medications, health perception, nutrition, elimination, thyroid, hyperthyroid, hypothyroid affects all systems of the body. Sleeping, cognition, reproduction, coping and stress. Nursing diagnosis. Cardiac output decreased, comfort impaired, ineffective health maintenance, risk for infection, imbalance in nutrition. They're burning through a lot of calories. Remember, everything's on hyper, so they may be taking in calories, but they may be having less calories than their body's requiring at this time because they're revved up for hyper. Disturbed body image, a lot of changes, a lot of things happening with them that they may be concerned about. Planning, experiencing relief of symptoms. Goal is to have no serious complications. Maintain their nutritional balance, and that they will cooperate with the plan of care. Make sure they're involved in the planning, that we're not just dictating to them what they need to do, that they understand and they have education in what they need to do. Requires aggressive treatment, medications to block thyroid production and sympathetic nervous system, monitor for dysrhythmias, make sure they have adequate oxygenation, fluid and electrolyte replacement, adequate rest, calm room, cool room, remember they're heat intolerant, light bed coverings. For eye care, they may need artificial tears, salt restriction, head of bed up, dark glasses. If they can't close, if their eyelids don't close fully, you may need to take their eyelids as needed for sleep. And exercise their ocular muscles. Pre-operative, administer medications to achieve euthyroidism, administer iodine to decrease the vascularity, decrease the bleeding risk, assess for signs of iodine toxicity, patient teaching, comfort and safety measures, leg exercises, head support, routine post-op care, immediate care, oxygen, suctioning, tracheotomy. Where are they having surgery at? What is that? What do we have a problem with there? No big deal? What can happen? They can have edema, right? What can that do? Block their trachea, the trachea. They can have a lot of bleeding, right? They can aspirate, correct? So their airway suction and is very important. Maintain their airway, their oxygen, their support. Be ready to put in a tracheostomy. Have the tray ready because it may come to that. Monitor their breathing, monitor their IV calcium. Make sure the IV calcium is ready. Assess them this is every 2 hours. I think you're gonna assess them a lot more often than every 2 hours. Semi-Fowler's position, support their head with pillows, avoid neck flexion, and avoid tension on their suture line. Vital signs, calcium levels, signs of hypocalcemia, difficult speaking and hoarseness, signs of hypocalcemia, analgesics, ambulation, psychosocial support. Just the appearance of that incision on their neck may be distressing to a patient, right? You know, they're gonna have a scar. For some people, that body image, that would really affect them. So you can also reassure them that the scar is it's gonna fade as they heal. It's not gonna be so pronounced. And scar for jewelry, encourage them with a covering that can camouflage that scar. Monitor for complications, hypocalcemia due to the damage to the parathyroid when they're in their thyroid, hemorrhage, laryngeal nerve damage, thyrotoxicosis, infection. ambulatory care, monitor hormones periodically, decrease their caloric intake. They've been revved up and high, right? Do I need 6,000 calories now? Avoid increased environmental temperature, regular follow-up, regular exercise, adequate but not excessive iodine intake. If they had a complete thyroidectomy, watch for symptoms of hypothyroidism. They're gonna need lifelong thyroid replacement treatment, and the dosage may need adjusting. Evaluation. Expect outcomes that they're gonna have, that their cardiac status is gonna stabilize, and maintain, they regain and maintain visual acuity. They're gonna have the appropriate amount of calories per day, no weight loss, no weight gain, or excessive weight gain. They communicate feelings about changes in their body, they're coping. They understand the importance of the daily medication and the treatment regimen. If patient outcomes are not met, additional education may be needed. A patient not following prescribed diet or medication regimen, explore the reason why. Don't just label them as non-compliant, and investigate as to why that they're not doing what they need to do. It could be they have a knowledge deficit, or there could be something else afoot, and develop a care plan that they can live with and that meets their needs and meets their goals as well. Any questions?